Learn. My name is Jackie. I'm so glad to be here with you guys. Happy Thursday. We're going to get started in just a couple minutes while we make sure we're up and running on all of our channels. So again, happy Thursday. Welcome. We have a fun topic, fun and exciting and important topic to talk about today. We're going to talk about blood administration. So we will get started with that in just a couple seconds, but give us just a quick minute and we will get going. Good to go. Okay, all right, we're good to go. Well, welcome back, everybody. My name is Jackie. I'm a nurse here at UWorld, and I'm so excited to be back with you guys for another Live and Learn today. We're going to be talking about safe blood administration, but just a reminder, our Live and Learn schedule. Make sure you like and subscribe your favorite channel to your favorite channel, because you guys will get updates on when we go live, what our topics are. You'll be able to see in advance what we're talking about, so you can sign up and get notified. So don't forget, like and subscribe. We'll keep you informed. But again, we're live Tuesdays and Thursdays at noon Central Time on YouTube, Facebook, TikTok, and Instagram. So make sure and check us out. We also have on-demand viewing available on Facebook and YouTube. And then kind of wrapping up this week, today, safe blood administration. Next week we have what we're calling tough topics, and we're going to talk about hypercapnia and COPD, and then we're also going to talk about electrolytes, which is like, ooh, tough topic. So I'm excited to be back to join you guys for that, and electrolytes are maybe one of my favorite things to learn in nursing school. I don't know why, but it's a good topic. It's extremely important. So join us next week. Again, Tuesdays, Thursdays, noon Central Time. Today, again, we're talking about blood. Make sure you use that chat feature. Ask us questions. Tell us how we're doing. As always, let us know what you guys want to hear, because we're looking and we're watching and we're building our content to really support you guys. So just keep us informed, and we'll go ahead and get started. So before we get started, though, talking about blood administration, I thought it might be helpful just to reference back to that NCLEX test plan. So we talked about this a couple of weeks ago on our NCLEX Meds Mythbuster Live and Learn. And so I just want to reference it again. So the NCSBN, which is like the maker and distributor of the NCLEX, they put a test plan out for everyone to see. And it really breaks down the percentage of what we call client need categories. And it gives you an idea of how much of the test is going to be on those client need categories. There's tons of helpful resources on there. And so we encourage you guys, go to NCLEX.com, take a look. It's like your teacher giving you a study plan for a test. So take advantage of it. It's free resources. It's there to help you. It's there to kind of relieve some of that what if about the NCLEX. So take a look at it. But again, we're going to reference that in our lesson today on blood administration and what the test plan really says about it. So in reference to the test plan, I wanted to share the exact language about how blood transfusions are referenced. So again, we're going to frame our conversation all about that, so we know we're addressing what the NCLEX is looking for about blood. And again, this is coming straight from NCLEX.com. Under the Prepare tab is where you can find the test plans. So let's take a look. It says under pharmacological and parental therapies, which is currently 13 to 19% of the test, the first bullet point under there is administer blood products and evaluate client response. Then the test plan gets a little bit more specific, and it tells us exactly what we need to know about that. So specifically, we need to know how to identify the client according to facility agency policy prior to administration of red blood cells / blood products. So we're going to need to know about red blood cells, and we're going to need to know about other blood products. This is going to include like an order for administration, correct type, correct client, cross-matching, and consent complete. The next bullet point talks about checking the client for appropriate venous access for red blood cells and blood product administration. So things like correct needle gauge, integrity of access site. Then it's going to ask us to be able to document necessary information and then administer blood products and evaluate client response. So again, it's kind of working us through that nursing process of why we're giving blood, how we're giving it, how we know we're being safe about it, and how we know it worked. So again, knowing this is kind of how I framed our conversation for today. So we'll go ahead and jump in. So let's start off by talking about why we might need a blood transfusion. So essentially we're going to give blood to replace blood or blood components that we've lost. So think kind of hemorrhage or critically low levels is another reason why we're going to give it. So think different disease processes. So during emergency situations like surgery or trauma, when hemorrhage happens, we'll administer blood. So same kind of idea for like labor and delivery. We might give blood during labor or after delivery. But we also are going to give blood for supportive care for clients experiencing like anemia or thrombocytopenia. So a lot of times this can be secondary to like cancer or chemotherapy treatments. We give blood to increase our hemoglobin or our platelets because cancer has infiltrated our bone marrow, and those healthy components of blood that we need to flourish are kind of being stifled by the overgrowth of cancer cells in our bone marrow. So big picture, we're giving blood when blood is coming out of our body in like a big way, and we're giving blood when blood is not being made in our body. So let's talk about the different types of blood products, because we don't just give red blood cells, but we're going to start there for our discussion. So packed red blood cells are given to increase our hemoglobin and hematocrit. So as a reminder, hemoglobin is what carries the oxygen in our blood. So we're going to give that to clients that have anemia. We can give platelets, which are part of the treatment for thrombocytopenia or low platelets. Another element we can give is fresh frozen plasma or FFP. So this is given to clients that maybe have a deficiency in clotting factors. So this can be clients in the acute stages of blood cancer or clients experiencing DIC. So DIC is disseminated intravascular coagulation. And if you're not familiar with DIC, it's definitely a medical emergency. And essentially, it's a condition where you are clotting and you are bleeding at the same time, but in a way that can be fatal if not treated. So remember, FFP is for DIC. So that's packed red blood cells, that's platelets, that's FFP. Next we have cryo, which is essentially a concentration of specific clotting factors that are found in FFP or found in our plasma. So that might sound a little bit tricky, but just remember FFP is plasma, so it's going to have like an array of clotting factors in it, and cryo is more like a very filtered out specific version of FFP. And last but not least, we can also have frozen red blood cells, which are typically for autologous blood transfusions, or essentially we're taking our own blood, we're freezing it, and we're saving it in case we might need it for an emergent situation. This is really done for clients with rare blood types where it might be hard to find a match, and that those clients might be having surgery or needing it for something very specific. A point to point out, when we freeze blood, it lasts longer. So it's kind of like the same type of principle with food. Food in our freezer is going to last longer than food in our refrigerator. So that might be a reason why we would freeze it. Okay, we'll take a break like we do. We're going to do a little knowledge check. So make sure you guys use the chat and drop in the chat the component of blood you would give for thrombocytopenia. So what will you give clients experiencing thrombocytopenia? Let's go ahead and check the chat. See what we got. Again, what type of blood component would we give for thrombocytopenia? It could be red blood cells, it could be platelets, it could be FFP or cryo. Let's see what we got. I think it's starting to come in now. Very good. Simran said platelets. Very good, that is correct. Jessa, platelets. Jerry on YouTube, platelets. Good job, you guys. Awesome. So yes, that would be what we would give for thrombocytopenia. Okay, so checking back in with our test plan reference, we've covered the first part, which is the order for administration, by talking about the different components of blood we can give. So let's talk about the correct type now. Okay, so you guys just have to stick with me on this. It's going to be We're all going to be okay. We're going to make it through, and I'm very hopeful that this will be a good way to help it stick in your brains. Okay, so we're going to talk about ABO compatibility and RH compatibility. This is so critical because if we don't follow our facility safety checks and know this information like the back of our hand, one little oversight can be completely life-threatening to our client. And I don't say this to scare anybody or freak anybody out, but if we just stick to the rules, follow the plan, everyone will stay safe. But this is really one of those things we really need to know inside and out. So again, we need to know ABO compatibility to make sure the blood the client is receiving is going to get along with the blood that's already in their body. So we have a really great image we're going to bring up now so you guys can see, and it's going to outline the differences between everything we need to know, and we're going to kind of walk through this together. So we'll pull that up for you guys. And we're going to start by looking at the row header across the top and the column header down the side, and we're just going to work our way through. So we have ABO compatibility and RH compatibility for our blood groups. So think of the ABO as like the blood's first name and the RH part as the blood's last name. So our RBCs are going to have surface antigens, which essentially name our blood type. So type A blood types are going to have A surface antigens on them. B blood types are going to have B surface antigens. AB are going to have both A and B surface antigens, and O is not going to have any. So, okay, this is where we're going to really paint this picture of blood for us. Okay, I want you guys to think of the RBCs as like little boats, like just tiny little canoes in our blood. Okay, so if the RBCs are little boats, so if we are type A blood, only letter A's can be in the boat. We can only have A's in the boat if we are type A blood. If we are type B blood, we can only have letter B's in the boat. And then if we are type AB, we can have both letters A and letters B, which is so great. Like blood type AB is such a great host. Everyone's welcome on the boat. But for type O blood, nobody's on the boat. Nobody can come in, but that's okay. It sounds harsh, but it's okay. Okay. So stick with me. We have our RBC, which is the boat, and we have our antigens, or our blood type, which we're visualizing as a boat filled with that letter or filled with that antigen. So now let's talk about what our boats are floating in, which is going to tie back to the antibodies. So in this like little visualization we're doing, both letters A and B have to be accounted for. So for our type A blood, our boat is filled with the letter A. So that means the water or our blood serum is going to be a pool of letter B's. So our A's are in the boat floating in a pool of B's. So essentially they are, the B's are not allowed in the boat. So blood type A has A antigens and anti-B antibodies. So same idea for blood type B. Our boat is filled with the letter B, so that means our water or our blood serum is going to be a pool of letter A's. So essentially, they are not allowed in the boat. A's are not allowed in the boat for B blood types. So blood type B has B antigens on the surface and anti-A antibodies in our serum. Okay, now AB blood. Since they have both A's and B's on the boat, everybody's accounted for, so there's no antibodies in our serum. Again, they are great. They are very generous. Everyone's allowed on the boat. And because of this, they are the universal recipient, so they can receive blood from anybody because everyone's welcome. So think recipient, who they will receive on the boat, which is A and B and O. Okay, so the opposite is true for O blood type. Since no one is on the boat, that means both A and B antibodies are in the serum or in our water that we're floating in. So because of this, people with O blood type can only receive blood from other O-type bloods. So they only like empty boats. Nobody is allowed in their boats. But they can give blood to any blood type because their boat is empty. So they can give blood to A's, B's, AB's, and other O's. Okay, stay with me. I don't know what boat you're in, but we're all floating and we're all sticking together. Okay, so let's see who we can donate and receive from. Okay. So A blood. A blood types can give to other A's and AB's because the A antigen is present or the letters on the boat will get along. So as long as there's an A on the boat, we can go there. Okay, so A blood types can only receive from other A's and O's because, again, it's all about who is on the boat. Since the O boat is empty, it works. So again, A blood types can give to A's and ABs because the A's are on the boat, but they can only receive from A's and O's because that is, they will not accept a B, essentially. Okay, so B's, same principle. B blood types can give to other B's and ABs because the B antigen is present, or the letters on the boat will get along, but B blood types can only receive from other B's and O's because it's, again, all about who's on the boat. Okay, AB, we've touched on this. AB can only donate to A and B because they are the only blood type with A's and B's on their boat. They're the only one that have the A antigens and the B antigens. But AB can receive blood from anybody because everyone's welcome on their boat. They have the A's and they have the B's, and the O's can be there because their boats are empty. Okay, O. All right, it sounds harsh. Their boats are empty, but it's okay. It works. Okay, so O's can give to anyone. Again, no one's on their boat, so there's no surface antigens that can cause problems. But O can, and this is why O's are your universal donor. Because their boats are empty, they can go on any boat. Okay, but O can only receive from other O's because it only welcomes other empty boats. O's only like empty boats. Okay. I'm curious to check the chat and see what you guys are thinking. I hope this boat thing worked. If all else fails, you just memorize this chart and you'll be okay. But I wanted to try and kind of get you a little bit better of an explanation. Okay, so we've covered the first name, which is like the A, the B, the AB, and the O. Now we're going to talk about the last name, which is the RH, the positive or the negative. So same principle. If we are RH positive, that means our boat is filled with positive signs. So we can give to other positive signs because the signs on our boat will get along. But we can receive from positive or negative because the negative does not have any surface antigens on it, so everybody's going to get along. Okay. If we are RH negative, since we don't have surface antigens, we can donate to RH positive or RH negative blood type because the boat is empty. But we can only receive from other RH negative because we only welcome empty boats or no surface antigens. So being extra specific, like O negative is this actual universal donor because it's totally lacking any surface antigens. There's no A's or B's on it, and there's no positives on it. So that is what our universal donor is. And AB positive is the universal recipient because it accounts for everything that can be on the surface of our blood. And AB positive is like an extremely rare blood type. I think it's like less than 4% of our population is AB positive. I know that was a lot. Again, I'm going to check the chat. I hope you guys are on a boat with me. If you're not, I'll bring you aboard. We can just walk through this a few more times on demand. You can listen to it again. Okay, so we're going to put a question in the chat for you guys. What types of blood can AB blood receive? So if you are AB blood, what type of blood can you receive? So who can you welcome on your boat? Your boat is filled with A's and B's, so who can you welcome in? Let's see what you guys think. All right, on YouTube, we have Mystical 1824, all blood types. That is correct. Good job. See if anyone else is coming through. I'm starting to see some AB. Yes, Nisa, AB, ABO. That is correct. Oh, good job. Okay, you guys are on a boat. I love it. Lucy said all on Facebook. Good job, you guys. Jerry again said all. Very good. Awesome job, you guys. Okay, one more question. What type of blood can O blood receive? So if you are an O blood, what type of blood can you receive? So again, O blood. There's no one on your boat. So what type of blood can you receive? Drop it in the chat. Let's see. Let's see. Who can O bloods receive? Yes, Mystical 1824 said only O. That is correct. Lucy on Facebook said O. Simran on YouTube said, oh, very good, you guys. This makes me feel like maybe the boat thing worked, and if not, again, just you can make a little card for yourself and just work your way through it and find the right way that works for you. Okay, so good job, you guys. Now we're going to talk about blood administration setup, so what it actually looks like to give blood. So this is going to address the second bullet of our test plan, and we have another image we're going to pull up for you guys. So starting off, we need access. This can look like a large bore IV access site, so something like an 18 gauge. So remember with IVs, the smaller the number of the gauge, the bigger the opening of the catheter. We can also do things like a central line or a PICC line to administer blood. But most importantly, we need to make sure the access point works before we pick up the blood, because we are working against the clock once you pick up the blood from the blood bank, and you don't want to mess with trying to start an IV when you're under pressure. We also need special filtered Y-type tubing. So the Y is important because it is going to allow us to merge the blood in with our fluid, and this fluid can only be 0.9% sodium chloride or normal saline. So I'll say that part again. Only 0.9% sodium chloride or what we call normal saline can be hung with blood. No other fluids are compatible with it. Okay, that's a very important safety thing to know. Okay, so the blood and normal saline are going to meet in the drip chamber, and this is where a filter is going to catch any clots. So this is why that filter tubing is so important. We need something that's going to catch the little clots in the blood if that is the case that it's in our blood. Okay, we also need an infusion pump. So we want to be very specific and calculated when we give blood, and a pump is the safest way to do this. So we don't want to give blood too fast and cause harm to our kidneys, or too slow because blood has a specific shelf life out of the refrigerator, because again, bacteria can grow. Same principle as food. We can't have our blood be out of the refrigerator too long because bacteria is going to infiltrate it. Okay, I have just like a handful of little never do this and always do this. Okay. So things we never do when giving blood. We never give blood with any other fluid besides 0.9% normal saline. We never add medications to blood products because we don't want it to interact with anything. We have to have blood be solely isolated, be the only thing infusing in that access point. And we never reuse tubing. Again, we can't have blood sitting in tubing outside of 4 hours or else bacteria will begin to grow. Okay, so those are our nevers. These are some always that we want to do when we're giving blood. So always check the blood bag for the date of expiration. We don't ever want to give blood that's past expiration because that could cause extreme infection inside our body. We want to always check the blood bag for leaks, color, discoloration, clots, or bubbles. Anything that looks like something could have infiltrated inside the bag, we don't want to be giving that bag to our client and cause them any harm. And we always, always, always want to be ready to give our blood before we pick our blood up from the blood bank. It needs to be started within 20 to 30 minutes or per your facility protocol, and immediately return to the blood bank in that time frame so it can be properly stored and not wasted. So if for some reason you get your blood, something happens, you need to have it back to the blood bank so it can go back in the correct refrigeration method within that 20 to 30 minutes. Otherwise, we have to discard the unit of blood, and we don't ever want to waste blood. Blood is so important and it's life-saving to so many people, so we want to make sure and utilize it the best we can. Okay. So let's talk about the administer blood part of the test plan statement. So first things first, safety always. All of the interventions and rules around blood administration are to keep our clients safe and prevent any infections or complications. So starting off, we want to make sure that the client has consented to the blood transfusion. So this means that they know why they're getting blood and they know what product that they're going to get. So in case of an emergency and if the client or the family member is not able to consent to blood, it's up to the physician to do what's best for the client and say yes or no to blood. Okay, we also want to make sure their IV access is working. So we want to give it a flush before starting. Again, we don't want to run into any problems when we pick up that blood from the blood bank. Essentially the clock starts and we just want to be able to have this process go as smooth as possible. We also want to take baseline vital signs before we start blood to be sure that there aren't any red flags that are findings that we would want to follow up with. Anything like fever or really high blood pressure, anything that might indicate like a fluid volume imbalance. Next, we want to verify our client with another nurse using 2 client identifiers. So this could be like name, date of birth, medical record, but we always want to have that communication of saying a point of information and verifying it with another client or with another nurse. Okay. We also need to verify the blood type of the client and the donor to ensure they are compatible. So this is where understanding that compatibility chart is really going to be important and where it's really going to need to be essential. So again, we want to make sure that what we're getting from the blood bank is compatible with the blood type of the client. And again, a quick highlight from our boat discussion. All that matters is the letters on the boat, that they're welcoming to the letters on the boat coming in through the blood. So just think about it's all about who's on the boat. Okay, so next we're going to review the expiration date of the blood and the unit number to make sure that what's on the bag is matching the order in the computer system or the information you receive from the blood bank. So there's all these checks in place to make sure that the blood we're giving is safe. So assuming everything checks out now, you're going to spike your blood with your Y-site tubing and you're going to begin the first part of your transfusion. So we're going to stay in the room for 15 minutes and then we're going to check vital signs. We do this because as soon as the blood hits the client's vascular system, we want to monitor for any adverse reactions like a transfusion reaction. So we want to be in the room, so if this happens, we can immediately stop the transfusion. This is something that we cannot delegate to anybody. You cannot delegate those first 15 minutes to anybody but yourself. You are responsible for this. So after the first 15 minutes, we're going to check vital signs, and then we're going to check them again every hour. And you're going to change the rate of infusion after that first 15 minutes too. We're going to start off very slow so that only a small amount of blood is getting into that circulatory system, and we're making sure that there's no reactions. And then after that, you can speed it up to a rate that is appropriate for your client. So a good rule of thumb for giving blood is to give the unit between 2 and 4 hours from the starting time. But again, you want to check with your facility protocol or your facility policy when you get into practice. But we definitely don't want to go past 4 hours because that's when bacteria can be introduced into the system. Okay, so we'll talk about transfusion reactions, and we're in the home stretch now. Okay, so I've seen a handful of these in my time. I have a background in oncology nursing, so we gave blood just as often as we would give fluids or antibiotics or any type of medication. Again, it was life-saving treatment for those types of clients, so it was something we did every shift. But when someone is having a transfusion reaction, a lot of times you'll see it present like chills, fever, rash, shortness of breath, or tightness in the chest. So assessing for a transfusion reaction would be part of the test plan activity statement, to monitor when it was asking about monitoring the client's response. So again, if you see this, this is not good. It's not a therapeutic treatment for our client at this time. So if this happens, first things first, stop the transfusion, turn the pump off. Do not let any more blood go into that client because it's going to cause more harm the more blood that goes in. So again, stop the transfusion, then you're going to disconnect the tubing from the client. You're not going to disconnect the IV site, you're just disconnecting where the tubing connects to the IV site. We need that IV site to administer medications that could potentially be life-saving for the client. So we're going to want to get brand new tubing and infuse 0.9% sodium chloride or normal saline. Again, that's the only thing that we give with blood, and it's what we want to infuse after we give blood too, to flush the line out. And we're going to use that in new tubing because again, we don't want to push any more tubing or any more blood that's not compatible into the client. So clients can experience anaphylaxis, so we might need to give medications like epinephrine or even Benadryl, and so that's why that IV site is so important to leave in. We need the IV site. We do not need the bad tubing. So that's what we're going to do. Okay, so we're also, if a transfusion reaction happens, we're also going to want to collect a blood specimen and a urine specimen. So this is going to see if there's any significant damage happening in the body from that reaction. So we're going to do that. We're also going to want to notify the blood bank and return whatever's left in that blood bag to the bank so they can take it and do further testing and maybe see what the problem was. If it was an antibody or something that wasn't compatible, they'll be able to do that testing. So we don't want to throw it away. We want to save it and send it for investigation, essentially. We're also going to want to notify the healthcare provider and let them know what happened. And then we have to document this. We have to have record that this reaction happened so that it doesn't happen again. So we want to document the incident, what actions we took to keep our clients safe, and how the client responded. If they had a positive response, maybe it meant they had to be transferred to the ICU, things like that. We just need to do a good job documenting. Okay, we did it. We made it. I hope everyone's still on our boat with us. So that's what we have for blood right now. And we will wrap this up with a question. So we'll pull up a question for you guys and go ahead and read it. And feel free to drop your answers in the chat. So I'll read it through and then we'll go through and talk through it. Okay, so we have, the nurse is preparing to administer a unit of packed red blood cells to a client. Which of the following actions should the nurse take? Select all that apply. Okay, so we are giving blood. We're seeing what things we should do. And so it's a select all that apply, so we're going to have more than one right answer. And we're going to take a true-false approach when we look at these. So if it's an appropriate action, it's going to be a right answer. If it's an inappropriate action, it's going to be a wrong answer. So I'll read the options, and I'll let you guys put your answers in the chat, and then I'll walk through it. Okay. So first, prime the Y-type tubing with lactated ringer solution. Option 2, insert an 18-gauge peripheral venous access device. Option 3, administer the unit of packed RBCs over 2 to 4 hours. Option 4, obtain the client's vital signs prior to initiating the transfusion. Option 5, verify the client identifiers with the unlicensed assistive personnel. All right, so let me see what you guys are saying in the chat here. Feel free to drop your answers in, and we will go ahead and walk through it. Okay, seeing some stuff come in. Looks like you guys are getting it. All right, so option 1, prime the Y-type tubing with lactated ringer solution. This is not good. We do not do this. The only fluid we ever use with blood is normal saline, or 0.9% sodium chloride. So this is not going to be one of our answers. Option 2, insert the 18-gauge IV. This is true. This is what typically is preferred when we're giving blood. A large bore catheter or needle is helpful. So this is a true answer. So option 2 is going to be a correct answer. Option 3, administer the unit of packed red blood cells over 2 to 4 hours. We know this is true also. Anything over 4 hours is going to cause bacteria. Anything maybe under 2 hours might be a little too fast for a client, and we don't want to cause any of those that harm, like circulatory overload. That might be too much fluid too fast. But again, there's some stipulations around that, but for this purpose, just know 2 to 4 hours. So that's a true statement. So far we have 2 and 3 are correct answers. Option 4, obtain the client's vital signs prior to initiating the transfusion. This is a true statement. As we always say, we have to know where we're starting to know where we want to go. So for blood, we want our vital signs to either show improvement, so more fluid, better perfusion, better breathing. We do not want it to show negative signs. So we have to have a baseline to make sure we're headed in a good direction. So this is true. And then option 5, verify the identifiers with a UAP. So again, we talked about this. No part of blood can be administered to, or blood administration in the room can be administered to a UAP. It's all the responsibility of the nurse. So this would be a false statement, not a correct answer. So our correct options are going to be 2, 3, and 4. So hope you guys got those right. And that kind of wraps up what we have for today. We hope you guys will, as always, like and subscribe to your favorite channel. You can have an update on what Live and Learns we have, what topics we're going to be talking about. Next week, again, we're doing COPD and hypercapnia and some electrolytes, so we hope you'll tune into that. And we also really hope you'll check out our website. Go to nursing.uworld.com to check out our 7-day free trial. There's so many great resources on there, not only the free trial, but just general resources that can be helpful to you while you're in nursing school. We have just an amazing team of nurses here that are brilliant, and we're just here to help you be successful successful. We want you guys to do well in nursing school, be successful on your NCLEX, pass on the first try. And, you know, we just check us out. We know you won't regret it. So again, nursing.uworld.com, and we hope to see you guys next week. Have a great weekend. Bye.